Today we'll be having our Bloodborne Pathogens annual review by Dr. Dembry and Dr. Russi.
Good morning, everyone. I'm going to apologize because I'm getting over one of the really bad colds that's going around. And so, although I have my water, if I get a coughing fit, it takes more than water. It'll take me a couple minutes to get over it, at which point I'll turn off the microphone. Dr. Russi is running a little bit late, like I know a lot of people are, but I always start first. And so, in the interest of time, I'm just going to go ahead, and then when he gets here, I'll be able to turn it over to him. So, welcome. So, as every year, I say, why are you here? And it was already announced this is your annual training for bloodborne pathogens, which is something that OSHA requires. And I think it's the kind of thing, and I say this every year, it's good to go over the basics again, just to remind people about how to protect yourself. And Dr. Russi is going to spend a lot more time talking about safety devices in the OR and also what to do should you get a sharps injury, which is really the type of injury that we're most concerned about because it has the highest risk of transmission. So on that note, I'm going to start with this. So bloodborne pathogens, we normally think about it as HIV, hepatitis B, and hepatitis C. I think it's good to remind ourselves that there's a lot of other organisms that are also transmitted through the bloodborne route. And whenever there are things like emerging infections, one of the big things we talk about is that something can be through the bloodborne route. And I think you all know from Ebola in 2014, there's Ebola again in the Congo right now, that bloodborne transmission is certainly the way that is most commonly spread. So we are going to focus on what I call the big three viruses, but remember there's a lot of other organisms that are transmitted this way. So methods of or modes of transmission in the healthcare setting, the one that we're most concerned about is percutaneous, and that's what we're going to focus on today. That's the one that you as surgeons are also at highest risk for. But we need to remember also too, there's potential for transmission through the mucosal route. Depends a little bit on the virus. Certainly some of them like hepatitis B can certainly be relatively easily transmitted through the mucosal route, meaning should you get a splash to your face and conjunctiva, you can actually get hepatitis B that way. Or direct inoculation of the virus into broken skin. This is something that we don't see very commonly. The risk of transmission tends to be relatively low, although it's not zero. So the risk of infection varies with the pathogen, as I already commented on, the type of exposure, meaning is it a sharps injury versus a splash to non-intact skin, the amount of blood involved in the exposure, and then the amount of virus in the patient's blood at the time of exposure is very, very important. And we have a lot more data on that now around hepatitis C and HIV, and again, something that Dr. Russi is going to comment on. So not all exposures are equal, I think is what I want to make a point about that. So there are about 8 million healthcare personnel in the United States. Close to 600,000 sharps injuries a year. More than half of those occur in hospitals. We do have to think about out-of-hospital settings, but I think for your purposes as surgeons, the in-hospital OR setting is really important. And of those sharps injuries or percutaneous injuries, 2/3 of them are from hollow bore needle sticks, and those are the most risky ones. About 14% are from sharp tip suture needles, and a number that has remained relatively steady is up to about half are unreported. Some studies it's higher than half, some it's a little bit less, but 50% underreported or not reported continues to be the statistics that we hear. Surgeons report only about 1/4 of their sharps injuries. And most of the injuries, and this also is the same thing in the OR, is after the device has been used. So it's not as common as during use, but mostly after use. Sharps injuries in the OR, very, very important issue. Sharp tip suture needles cause most of those injuries. Do need to be aware, though, that there are other types of sharps injuries in the OR, and most of those are related to devices that don't have safety features to them. As you can imagine, surgeons are at the highest risk in the OR, but scrub personnel, anesthesiologists, circulating nurses also are at risk. And among surgeons, trainees are at higher risk than attending surgeons for having a Sharps injury in the operating. So this was a study. There's actually two parts of the study. I'm going to mention the other part at the end of this section. But this was a study. This is at a single academic medical center over a 10-year period, looking at their administrative database. And they looked at about 333,000 surgery procedures, and they looked at a little more than 2,100 bloodborne pathogen exposures that they analyzed. And they came out with a rate of about 6.3 bloodborne pathogen exposures per 1,000 surgical procedures. And they found that the exposure rate was highest with higher estimated patient blood loss, also with duration of procedure, and also they saw there was some associations were generally stronger when they were looking at the suture needle related exposures than the other Sharps injury exposures. What was also of interest in this is, as you can imagine, most of the Sharps injuries, almost half were related to suture needles, and close to half of these were related to a fellow resident or a student having a Sharps injury. That was 40%. So as you can imagine, and that can be a variety of things. It can be that they're not as facile with doing this type of work. They're not as familiar with the instruments, and so they're at somewhat higher risk or are at higher risk for Sharps injuries. This was another study that looked at changes in needlestick injury prevalence after there was a change to the bloodborne pathogen standard in 2001 that required medical facilities to accept safety Sharps devices if one was available on the market and the frontline users would accept it. So I have a slide on this later, but I'll just give you a little background now because it fits in probably better here. In 2001, what OSHA recognized was that medical facilities were not really very accepting of safety devices. When the bloodborne pathogen standard first came into being in 1992, there were very, very few Sharps devices on the market. And the ones that were on the market were not easy to use. They were kind of cumbersome and actually in some cases caused more injuries than the non-safety devices. And so, you know, healthcare facilities didn't really make it a priority to take these on. But when the intervening about, you know, almost decade, the market caught up with this and developed safety devices that were easier to use, more intuitive, and would not actually cause more harm, but less harm to the user. But medical facilities were still not really very accepting of them, or healthcare personnel were not very accepting of them. So OSHA in 2001 revised their standard and said, you have to take a safety device if one exists on the market, and you have to include frontline users in evaluating safety devices because they're the ones who are going to use it, and see what they will use and then make that available for them. So in this study, what they wanted to do was look at Sharps injuries in attitudes after the bloodborne pathogen standard had changed in 2001 to see if any of those attitudes had changed among healthcare personnel. They looked at, this is a relatively small group, but they looked at medical students and Department of Surgery staff, and about, close to 40%, there were 38% reported that they'd had needlestick injuries. Most of those were in the OR, and 11% were reported as high risk. In this study, they defined high risk as the possibility that the source patient could have hepatitis B, C, or HIV. So it didn't have to be documented, they had it. When they looked at, in the survey, they asked people and said, so when you had a needlestick injury, why do you think that you had the injury? What happened? What was the cause? And about half of them said, well, it was probably something accidental or careless on their part. Almost a quarter said that they were rushed, and so they were rushing through doing something, and that's how they got injured. Another thing that's very important is 29% reported being stuck by another individual, and many times that's something that we see in the operating room. And again, here in this case, about a third or so said that they'd had at least one unreported needle stick injury. And in this study, it didn't matter by position whether you reported it or not. And then some of the reasons for not reporting needle stick injuries, the most common response was that it was inconvenient, and the second most common response was that it was too time consuming. They also asked on the survey, so you know what's the seroconversion rate of if you have a needle stick to HIV, hepatitis B, or hepatitis C. And interestingly enough, a lot of people believe the incidence was actually lower than it really is. A small percentage of them knew the incident. A very, very small percent thought the incident was higher than reality, but then also a large number of them said that they didn't know really what the risk of transmission was. They asked them about prevention practices. About 80% or close to that said they always double gloved. It was higher among medical students, much, much lower when you got higher at levels of training among the fellows. And those who did not double glove, they responded they felt there was not a need, was the reason for not doing it. About 79% also said they always wear eye protection, and 80% had received hepatitis B vaccine. They didn't ask in this survey if they hadn't received hepatitis vaccine, the reasons why not. I kind of find this a little bit low, but you know, again, this is a relatively small group. I don't know what the age range is. We don't know whether any of these people had hepatitis B, and that kind of thing. But I still found that a little bit disturbing that only 80% of these individuals said they had received hepatitis B vaccine. So the bloodborne pathogen standard, as I mentioned before, I'm going a little bit opposite order, but came into being in 1991. In 1980s, OSHA became interested in healthcare. They had not been interested at all in healthcare before that time. They were really more seen as protecting workers in the manufacturing industry. A lot of that was around accidents of, you know, losing limbs, losing life, those kinds of things with machinery. And so they had really stayed away from healthcare until HIV came onto the scene in the 1980s, and they got involved. And so they put together a standard that came out in 1991, and that said all healthcare facilities need to have an exposure control plan. So that's essentially a plan of how you're going to address and mitigate risks around bloodborne pathogens. Engineering controls, and these are control measures that will isolate or remove a hazard from the workplace, something where it'll help protect others. So a classic example of an engineering control is a needle disposal box. I can date myself. I trained in the 1980s, and I'll tell you in the 1980s, there were no Sharps disposal boxes. You just threw them away. You know, those of you, I can tell there are quite a few younger in the room. I mean, that would be unheard of to you, I hope, that, you know, you would not, you know, immediately go looking for a Sharps disposal box, but that's considering an engineering control. So a way to protect from the hazard. Work practice controls, this refers to things like not recapping needles. And then personal protective equipment is how do you protect yourself, the barrier between you and the source from being exposed to the bloodborne pathogen. So we refer to a lot of these protections now as standard precautions. The initial term was universal precautions, but the big change was standard precautions, and sometimes we use the terms interchangeably, but I just want to be clear is when we're talking about this is we want to use protections so that we can minimize, if not eliminate, exposure to bloodborne pathogens. And we have to assume that all patients are potentially infectious, regardless of their assumed risk. And so that is something that we think we all need to be careful about, because we do sometimes make assumptions, particularly when we have an exposure, about what's that patient's risk to me, and don't assume anything about an individual. Just based on age or background, you can't know whether that person is at risk for HIV or not, or hepatitis B, hepatitis C. So elements of standard precautions, as always, hand hygiene to protect yourself as well as the patient. Putting on those barriers to protect yourself from possible splashes or getting contamination on your clothes. Think before you're going to do a procedure about what you're going to do and what kind of barriers you should use to protect yourself. Patient care equipment that has to do with disinfection between patient use, environmental surfaces has to do with the environmental cleaning, and then injury prevention and follow-up, which Dr. Russi is going to talk about. So hand hygiene practices, I go through this pretty much every year. There's a variety of ways you can look at it. Maybe next year I'll talk about the WHO's 5 moments of hand hygiene. It's another way that people break it down. But you want to basically think about doing hand hygiene before you touch a patient, after you touch a patient, before you do a procedure, after you touch a procedure, after you've touched anything that's dirty equipment or environment, before you touch anything that's clean. Think about that and what the potential is that you might have some pathogens that you've acquired on your hands and that you will transmit it in some other way. Soap and water hand hygiene, something we don't talk as much about these days since we use a lot of alcohol-based hand rub, but I think it's important to remind people that this is where you want to be careful about how you do it and do it for the right amount of time. So it needs to be for about 15 seconds, 15 to 20 seconds, making sure to get all surfaces of your hands between your fingers, fingertips, palm area, thumb, etc. Waterless-based alcohol hand rub. So here at Yale New Haven and also at the VA, we use Purell, but there you work at other hospitals, they may have other brands. They all work very similarly. I think you all know this. You don't need a sink. You don't need to be able to, as a whole group, go troop off somewhere. There's a lot of alcohol-based hand rubs outside of patient rooms, inside of patient rooms. Something you can be doing as you're walking to the next patient, as you're discussing a patient. It makes it a lot easier to actually comply with hand hygiene. On this slide here, there's the little flag there, the little red flag, and that's to be able to flag that if you come across a dispenser that's not working or that's empty, put the flag up, and that's the flag to environmental services to change it out. These are frequently missed areas when we do hand hygiene. Just keep this in mind next time when you do hand hygiene, that you're actually paying attention to these areas. So basically kind of rubbing your hands like this is better than nothing, but it's really not true hand hygiene. So you want to get all surfaces between the fingers, fingertips. Sometimes you should not use alcohol-based hand rub. Alcohol-based hand rub does not remove dirt. It doesn't clean your hands. It disinfects your hands. So if your hands are visibly dirty, or if you got blood or body fluids on your hands, say for example, that your gloves tore when you took them off, and then you got some blood on your hands, you need to use soap and water to wash that away and actually clean it. Another time is when you're caring for a patient who has C. difficile diarrhea or also norovirus. And then after you leave that room and remove your PPE, you should use soap and water hand hygiene instead of alcohol-based hand rub. I show the 2 signs here because a few years ago at the VA, we changed all signs to look like Yale New Haven Hospital signs, and then they've changed them since then. We haven't changed ours at this point. But anyway, you'll see it'll say contact precautions plus, and it says on the sign to use soap and water hand hygiene. All right, quick moment about PPE. It's a major component of standard precautions, and this is what you want to do. Think about how you're going to protect yourself. Could you possibly get blood or body fluids on your hands? Wear gloves. If you could have splashing to your clothing or direct contact with that, say, a wound that is draining a lot, you want to wear a gown. If you could have splashing to your face, you're going to wear a mask and eye protection. Important piece in this is you need to remove your PPE. I say when you leave the patient room, the exact wording from OSHA is before you leave treatment areas, but once you've got that on, it's now contaminated, and so you're potentially putting your own self at risk if you keep that same PPE on and don't take it off. Gloves, always when you're going to anticipate contact with blood, saliva, mucous membranes, remove them after patient care. Gloves are for single use for single patient, and then do hand hygiene before you put new gloves on. And as I said, you got to think about whether you could have contamination in your clothing or you could get splashing to your face, then you need to wear the appropriate barriers. You go through this. Regulated medical waste, sharps. We have designated needle disposal containers everywhere. Before you're going to do a procedure using sharps, make sure you've located where that sharps disposal container is first, and that you know where you're going to dispose of your sharps. If for some chance you don't find a needle disposal box and you've already done your procedure, I wouldn't walk around with sharps trying to find it, but you want to immediately, as quickly as possible, find that sharps container nearby and then dispose of your sharps there. And that's a good thing to let people know, is if you feel that they're not in places where you need them, there's always more sharps containers that can be acquired. If they're past this 3/4 fill line here, you don't want to put anything more in it. That's the point at which it needs to be replaced. And so if you notice that and it needs replacement, let somebody know. Every state has different rules around what's regulated medical waste. In Connecticut, this is around bullet 2. If something is visibly dripping blood, so for example, if you were to remove dressings from a wound and it is so saturated that, I mean, it could be dripping, that's what we call redback trash. That's regulated medical waste that doesn't go into the regular trash. However, if it's got dry blood on it, it's got dry body fluids on it, that's regular trash. If you're not sure, don't ever squeeze anything to see if you get a drop of blood out of it, because you potentially expose yourself. But just imagine that if you were to squeeze it and there'd be a drop of blood, that's regulated medical waste in the state of Connecticut. Every state is different, so wherever you practice in the future, you'll always want to know what their rules are for that. Oops. All right, so I mentioned the bloodborne pathogen standard was updated in 2001, and that was to incorporate using more safety devices, which are considered engineering controls. And so we want to look at, when we look at this, it's from the perspective of OSHA was feeling, well, OSHA's feeling, data was there that about 77% or so of sharps injuries were probably preventable if it had some engineering control in place or a safety device or something of that. And the feeling was that, you know, about 10 years after the bloodborne pathogen standard came into being, that still having this many sharps injuries was too many and that we can do better. And so this was the push to say we got to start using safety devices. So this would be the ideal safety device. I don't know that there are any that really meet all these requirements, but they're getting pretty close, some of them now. They are much better than they were. You want a safety device feature that's integral to the device. Some of the early devices, you actually had to hook the safety feature onto it. And so you can imagine most people didn't do that, or they didn't understand what they were supposed to do. You'd like the device to work passively. You'd like the user to be able to know that the safety feature has been activated. It would be great if the safety feature can't be deactivated and it remains protective all the way through disposal of the device. Remember, most sharps injuries occur after the use of the sharps, and the whole disposal process is also a risk for the people who handle the disposal. And you'd like the device to perform reliably and have it be easy to use and practice. So what's been the effect of the safety of the 2001 change in bloodborne pathogen standards? So they've looked at, so this is one study, and it looked comparing rates before and after the passage of the law. And in non-surgical settings, injury rates were found to have dropped about 32%. However, in the surgical setting, injury rates increased slightly, was not statistically significant, but essentially remained unchanged. And most of those still being suture needles, and most injuries occurred during the use or passing of devices, which is a risky time, also in the OR. This is a group, this is the group that looked at 10 years of 333,000 surgical procedures, and they looked to see if you could correlate something around injury rates and how well a team works together. So they developed what they call like a team stability index. I don't know anything about kind of some of the social theory, but if you're interested in the article, it's interesting to read. But they basically said if the individuals on the team had worked together for over at least a 6-month period, they were considered a stable team. meaning that they estimate it takes about 6 months to get to know each other's practices and how they do things, and working together and communicating together. And for example, how to pass sharps and understanding each other. And so they found that basically the higher this index was, the less likely they had exposures to sharps, except for suture needles. And that's probably because when it comes to something around suture needles, some of that is individual, it's sticking oneself versus other individuals in the team. So it didn't seem to have as much of an effect on that. It had a slight effect, but it had a large effect on other sharps injuries in the OR, was this team stability index. So what can you do? You want to avoid needles and sharps where alternatives are available. That's not always possible to do, but certainly something you got to think about. If you are asked to be part of a group to look at safety devices, get involved, or even if you're not asked and you hear about it or you want to be involved, certainly, step up and do that. You're the ones who need to use them. Use the provided safety devices. Don't recap needles. I shouldn't even say avoid it, just say don't recap needles. Plan how you're going to dispose of sharps before you do a procedure. Dispose of them in the appropriate containers. Report your sharps related injuries promptly. That also helps, no matter what you think the risk is, it helps understand where injuries are happening and with what kinds of devices. And that can prompt more investigating what other options may be available on the market that could make things safer. And even some safety devices can still cause injuries. And I know it's probably been 15 or 20 years ago, Dr. Russi could say we had gotten a safety butterfly, which actually caused more sharps injuries than protected from that. And so, we removed that and then started looking at something else that would be safer. So it's really important to report your sharps injuries for your personal protection and also for the facility to understand it. You see hazards from sharps, report those, and then again, participate in training, follow all the standard precautions, and get vaccinated for hepatitis B. So I certainly hope everybody in this room is vaccinated. All right, on that note, we're right on time. And Dr. Russi is going to, you're just going to.
Thank you. It's nice. It's nice to be here. I imagine some of you who've heard this talk before could give the talk if anyone would like to. Let me just talk a little bit about HIV transmission to healthcare workers as well as HCV transmission to healthcare workers. Fortunately, HBV these days is not much of an issue because most of us have been vaccinated against that. This is the good news slide. So if you look at this, you can see that, and this essentially is all of the healthcare workers in the US who have become HIV positive from occupational exposure. This is right around where post-exposure prophylaxis was first implemented in the US. And since 1999, and this continues to be the same, there has been only a single case of seroconversion in a healthcare worker, and that was someone who was exposed to concentrated virus in a laboratory. I think that this is really attributable to two things. First, we have a pretty low threshold for administering HIV post-exposure prophylaxis. We very often give it when we don't know whether the source patient is positive or negative, but we know we can get the testing done on the source patient and know within an hour or two. So we get that first dose in as soon as possible because there is a window when it's effective. And very often, that's the only dose we give because we find out the source patient is negative. But this really relies on folks reporting their needle sticks. The other reason for this is that in the US, HIV positive patients are getting better care and tend to run lower viral loads. And of course, they're less infectious than they once were. That's CDC. Yep, just the US, yeah. Yeah, so this figure gets thrown around a lot, a 0.3% risk. That is several studies that were done back in the 1980s and 1990s. It's an off-quoted figure. It's certainly nothing close to what the current figure is, but that figure is, of course, in the setting of post-exposure prophylaxis being given to folks. It'd be very difficult to generate an estimate these days of what the risk is among healthcare workers, because the standard of care is to give prophylaxis. Dr. Dembry talked about the Needlestick Safety and Prevention Act, and suffice to say, there's a quite substantial range. We have about 25 different devices in use across the health system that have safety features associated with them. Just about all these data that Dr. Dembry and I are presenting are essentially passively gathered. So they are data regarding needle sticks that people choose to report. And so it's a little bit through a glass darkly, but that's a breakdown based on EpiNet, which is a national surveillance tool. You can see there the distribution. This is for mucocutaneous exposures, and importantly, this is an issue that NIOSH has become interested in, is we in general don't use eye protection enough. It's surprising, actually, sometimes the circumstances in which I see folks having gotten splashes to their eyes, including getting a finger stick for glucose. You wouldn't anticipate that, but we probably don't have a low enough threshold for protecting our eyes in a lot of the patient care that we do. This was a study, an important study published several years ago that was based on questionnaire surveys in 17 medical centers among surgical residents. The bottom line is that by the time someone was a PGY5, the average number of needle sticks they'd sustained was 7.7. By the final year of training, pretty much 100%, 99% of residents had sustained at least one needle stick injury. Underreporting was certainly present, and people were more likely to report the needle sticks that they were worried about if they thought the source patient had risk. The best way really to know how frequent needle sticks are is to actually be at the surgical a table observing what happens. This was a study like that done many years ago, where there were nurse observers at each operating room table, and the estimate from that was that in up to 15% of procedures, there was at least one needle stick. There are a number of studies that have looked at blunt needles, and suffice to say, pretty much all of them have shown that you can reduce needle sticks by using blunt needles. This was a well-done study. What was particularly good about it was that during this very long run-in period, they were able to look at the actual rate of needle stick injuries because they had observers right at the surgical table. And then they implemented blunts. The bar graphs actually show the increasing proportion of blunt needle usage, and blunts, of course, used mostly for fascial suturing, not for some of the finer aspects of surgery, but it's some of that fascial suturing where there's more pressure on the needle. And this implementation of blunts was associated with a pretty substantial decreased risk of needle sticks, and there have actually been a number of other studies that have shown that. Unfortunately, the response to blunt needles has been fairly tepid among surgeons. The ACS actually, as its official position, recommends them for fascial suturing, but there has not been a lot of uptake of them. We've tried a few trials here for them, and those have not been very successful. They continue to be available. Joe Lederer, if you're interested in trialing them, you can speak with Joe. Kimberly Davis in trauma surgery has also been involved in this. Double gloving also is recommended by the ACS. You saw the data from Dr. Dembry about the frequency of that. One that's a little more controversial is the establishment of a hands-free zone. A surgeon passes to a neutral zone, and the assistant picks up from that zone. Very many centers will do sort of a halfway version of this, where the instrument is handed directly to the surgeon, but the surgeon passes to a neutral zone. And the data, bottom line, have been mixed on this. There are studies that have shown this is beneficial in terms of reducing needle sticks. There are other studies that have actually not shown that. And ACS's position statement essentially says this is a technique that's recommended by OSHA and by the Association of Perioperative Registered Nurses, and it's something that should be considered. OSHA has criticized the surgical setting based actually largely on some of those passive data that needle stick injuries have not been reduced there. I think it's worth saying, however, that there are a number of changes in surgical technique that have probably resulted in greater safety. Electrocautery in place of scalpel, tissue staplers in place of suture needles, blunt-tipped suture needles, as mentioned, skin staplers and adhesive tapes in the place of suture needles at the skin, and blunt-tipped laparoscopic ports, and of course robotics are probably all steps that make it a little bit safer in the operating room. So as I mentioned, post-exposure prophylaxis has been a recommendation from the US Public Health Service since the late 1990s, and those recommendations have been updated on several occasions. You think about trying to figure out whether this works or not, it's actually pretty challenging. Burroughs Wellcome tried in the 1980s to get a trial off the ground, ideally like a placebo-controlled drug trial. But you sort of have to imagine you're at San Francisco General Hospital in 1985, you're taking care of an end-stage AIDS patient, you have a needle stick, and you go to employee health and they say, we're so excited you're here, we're doing a trial. And the response of people was essentially, look, if there is a drug that might help, give me the drug. And the trial actually never got off the ground. And so what we know about prophylaxis is really based on retrospective case control studies. And the one that was really the most important was a study that Denise Cardo down at CDC did, where essentially she demonstrated that among people who had seroconverted to HIV positivity following needle sticks, about 27% of them had used zidovudine prophylactically. Among people who had had similar exposures to HIV positive source patients but who had not seroconverted, about 36% had used zidovudine prophylactically. That doesn't sound very impressive at first blush, but when they went back and controlled for some of the things that impart higher injury, such as was the injury deep, was the device visibly bloody, did it involve a needle that had been in an artery or a vein, was the source patient terminally ill, was an index of higher viral load. And when they controlled for all these things, the estimate was that the odds ratio associated with use of zidovudine prophylaxis was 0.19, suggesting about an 80% reduction in risk. And this, of course, the only thing they could study in those days was zidovudine, because that's really all that was around. And this really was the most important basis of the recommendations. Yeah. What's that? Yep. So this is the crude difference. And when they actually stratified by these other things that impart risk, the model generated a p-value that was statistically significant. So this was the these are actually confidence intervals, not p-values here. So the 0.19, it was regarded that it was between 0.06 and 0.52. And the p was less. P was less than 0.02.
So as they looked at the data closer, they got something statistically significant from something that originally was not statistically significant?
Yeah, I mean, the concern was that there was enough potential confounding from the unequal distribution of those other risk factors between the case group and the control group, that when that was controlled for, there was a statistically significant difference based on the use of zidovudine prophylaxis. Yeah, it's an interesting result because, you know, the crude result at first was you know, was not a very impressive difference. Right. Though you could, you know, imagine. I mean, you can imagine if in your control group there was a substantial difference in the risk based on those other very important determinants of risk, and there was a substantial maldistribution of that other risk between the case group and the control group, that controlling for those things can actually cause the. What's that? Well, it wasn't, yeah. Yeah, yeah, right. This was another study that was done. This was actually a placebo-controlled intervention in HIV-positive pregnant women with zidovudine, and it was a trial that was halted midway through when it was shown that HIV-positive moms who got drug passed the virus to the fetus 7.5% of the time versus 22.5% in the placebo group. And what was interesting about this study was that when the investigators went back and controlled for viral load, they found no matter what the viral load was, there was still a profound drug versus placebo effect, suggesting that it wasn't just a drug reducing a virus in the mother so that less virions were available to get to the fetus, but the interpretation was that the drug being on board in the fetal circulation was actually preventing infection from taking hold. So those really were the two human studies, and then there have been a bunch of animal studies that have suggested an effect of prophylaxis. These days, the current guidance when someone has an exposure to HIV is to follow them for a 4-month period using the 4th generation assays. That's actually regarded as being an adequate period of follow-up to rule out infection. Unfortunately, sometimes the drugs don't work. There have been episodes of drug failure. Generally, those are attributed to drug resistance or the drugs being given too late or for an inadequate period of time. It's pretty important when an exposure occurs if the source patient you've been exposed to has been on a number of different antiretrovirals that there's a good look at what the pattern of resistance has been in that source patient. And so we work with the infectious disease attending of those source patients to come up with the right cocktail of antiretroviral medications. The recommendation these days is that 3 drugs be given immediately. And the likelihood of someone having a triple mutation is very much lower than a double or a single mutation. And that's really the basis of the change many years ago in CDC's recommendation that everyone receive 3 drugs. These days, the drugs that are given are relatively well tolerated. We made a change across the health system within the past year or so to Descovy and Tivicay. Descovy is a combination of tenofovir alafenamide and emtricitabine, and Tivicay is dolutegravir, which is one of the integrase inhibitors. Both well tolerated. In women of reproductive age, we do recommend a pregnancy test before starting dolutegravir. That's based on a study done in the last year, actually in Botswana, that suggested some neural tube defects in women receiving dolutegravir during pregnancy. Some problems with that study, and obviously a sort of poor nutrition area where it was done, but just that caution. Speaking of that, there are opportunities here at Yale, obviously, for folks to do outside rotations. At the sites where residents frequently go, we have established 28-day supplies of antiretrovirals, and we meet with each resident before the resident goes to those sites, and they get a 6-day packet just to get started in case they get a needle stick, and then if it turns out that the source patient is positive, they can access the larger supply. We have had folks from various departments, including this one and ENT surgery and plastic surgery, who go to sites in the developing world, sometimes for shorter periods of time, and provided them with post-exposure prophylaxis to take with them. The concern, of course, is that you could be in a setting where antiretrovirals aren't just going to be sitting around on the shelf, and if you had an exposure, you want to have to take. So hepatitis C, obviously there's been a lot of change with respect to hepatitis C. This is now a treatable and curable disease. And there have been some changes in recommendations for how hep C is managed post-exposure. Fairly early after infection, HCV RNA is actually detectable. And so the change that CDC made fairly recently is that when a healthcare worker gets exposed to HCV, that we do a baseline HCV antibody test. And anytime after 3 weeks, an HCV PCR that's negative is regarded as being adequate to rule out infection. So the follow-up period there is actually fairly brief using the HCV PCR. Suffice to say that there have been a number of studies in the past prior to the newer agents for hepatitis C that found differences in treating people for hepatitis C early in the course of disease rather than late in the course of disease. Now, of course, we have agents that are 97 to 99% effective in eliminating hepatitis C. The current IDSA, Infectious Disease Society of America guidance for management of acute HCV is that if an individual exposed to HCV became HCV PCR positive, that you would do actually a couple of follow-up PCRs over a course of 6 months to see whether the individual clears spontaneously. And if at 6 months that individual hasn't cleared, then you go ahead and treat with one of the combinations, sibosivir, ligotasvir, one of the various combinations for that. They also comment that a single negative PCR is insufficient to declare spontaneous clearance in someone who has once been positive. So those tests need to be done a couple of times just to make sure that infection hasn't taken place. We don't give post-exposure prophylaxis for hepatitis C exposures, and the main reason for that is that you would treat hundreds and hundreds of people for every one that actually would be destined to seroconvert. And of course, we now have drugs that can cure hepatitis C, which is very different from HIV. We have drugs that can only control HIV. With respect to the hepatitis B vaccine, the one thing that's worth mentioning is that many people these days got hep B vaccine as kids or teenagers, and when you get it as a member of the general population, you generally don't have a hepatitis B surface antibody done afterwards. Over time, if you look at people who responded to the vaccine and you follow them out about 10 years, about 60% of them will have hepatitis B surface antibody levels that wane down below 10 million international units. All of those folks remain protected. The trouble is if they never get a test until 10 plus years later and you see that it's negative, you don't know whether that's somebody who responded to the vaccine whose antibodies have come down, but who would go right back up if they were ever exposed to hepatitis B, or whether that's someone who was a non-responder to the vaccine. So when we encounter that, we generally give a boost and see what the response is. If the response, if they go right back up, then this is likely someone who had responded, whose antibodies have waned, but is still protected. Some people don't respond to hepatitis B vaccination, and those are individuals who need to receive hepatitis B immune globulin if they were ever exposed to the virus. Just maybe a couple of comments on bloodborne pathogen infected healthcare workers, just because it's really in the surgical setting where that has relevance. CDC generated guidance in 1991 that healthcare workers who carry out quote unquote exposure-prone procedures, and then basically what they meant by this was surgeries, should know whether or not they harbor a bloodborne pathogen, and if so, they should make that known to an expert advisory panel at their institution so that that panel can make a determination whether there need to be any changes in their practice in response to that. There have been some instances of transmission. There are 4 known transmissions from healthcare workers to patients for HIV. There are more transmissions of hepatitis C, and there have been actually several hundred transmissions of hepatitis B, most of them in years ago when hepatitis B was both more common among healthcare workers and where the precautions were not as stringent. There have been a number of studies that have looked back when surgeons have been HIV positive, and the results of those studies have been reassuring. There was very good guidance that the Society for Healthcare Epidemiology of America put together a few years back. Dr. Dembry is one of the authors actually on that guidance, and the recommendation is that for people who are doing procedures, surgical procedures, where there is some small chance they could transmit to a patient if they have a bloodborne pathogen, that their viral load should be monitored, and that if the viral load for HBV is or HCV is greater than 10,000 or greater than 500, that those individuals actually should not carry out those procedures. The recommendations are also that folks who harbor one of these pathogens should be monitored twice a year for that. Very rarely we have had to address a circumstance like that here. We have addressed it for hepatitis C, hepatitis B, and for HIV. Generally, the hospital has been permissive under these restrictions for allowing those individuals to carry out surgeries. So I think I'll end there. Are questions on any of this stuff, either the material that Dr. Dembry presented or that I presented?